Welcome to Health Code Blueprint. Today, we're covering the ICD 10-cm guidelines for Chapter 14, Diseases of the Genitourinary System, codes N00 through N99. In this session, we'll walk through the chronic kidney disease severity gradient, the priority rules for code assignment, post-transplant logic, and how comorbid conditions influence sequencing and overall coding accuracy. Disclosure: this presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. Before we jump into the coding logic, let's ground ourselves in the clinical definition. Chronic kidney disease is a long-term, progressive decline in kidney function. ICD 10-cm classifies chronic kidney disease by stage, which reflects how severely the kidneys are impaired. The lower the GFR, the more advanced the disease. For coding purposes, we focus on the stages most commonly documented. Stage 2, N18.2, mild CKD. Stage 3, N18.30, N18.32, moderate CKD. Stage 4, N18.4, severe CKD. Your responsibility is to match the code to the provider's exact documentation. If the stage is clearly stated, you assign it. If the stage is not documented, you cannot assume or infer it. And it's important to remember that we never assign a CKD stage based on laboratory values alone, including the GFR. The provider must document the stage, and we capture the appropriate diagnosis code based on that documented statement. Now let's talk about the terminal point of the severity spectrum, end-stage renal disease, coded as N18.6. Clinically, ESRD means the kidneys have lost nearly all function, and the patient requires dialysis or a transplant to survive. If the provider documents ESRD, you assign N18.6, no additional stage code is needed. Here's the key rule: if both the CKD stage and ESRD are documented, you only assign diagnosis code N18.6. The ESRD code overrides the stage code because it represents the highest level of severity. Let's move into transplant logic, because this is an area where coders often hesitate. A kidney transplant does not mean the patient's kidney function is fully restored. Many transplant recipients still have some degree of CKD, and if the provider documents a stage, you code it using N18 category. Then you add Z94.0, which indicates kidney transplant status. And here's the important part: the presence of CKD alone does not mean there is a transplant complication. To code a transplant complication, the provider must clearly document failure, rejection, or another complication of the transplanted kidney. If the documentation is unclear, meaning you're not sure whether the patient is experiencing a complication, the correct action is to query the provider. Never assume a complication based on labs or symptoms alone. CKD rarely exists in isolation. Many patients also have diabetes, hypertension, or both, and these conditions often contribute to kidney damage. Sequencing depends on the conventions in the tabular list. So always check for code first or code also notes. Don't assume the order, verify it. As you wrap up your code selection, run through a quick mental checklist. Did you assign the correct CKD stage based on documentation? If ESRD is present, did you remove the stage code and use N18.6 only? If the patient has a kidney transplant, did you apply Z94.0 appropriately? And if the documentation is unclear, did you query? These steps help ensure accuracy and compliance every time. Thanks for watching Health Code Blueprint. See you in the next video.